Alright, I'm back. Okay, so round 2. Baby's asleep now. That baby was tired. So here we go. So I'm looking at who should participate. Alright, so update from when I was here. I was reading this book, and then I spontaneously convinced myself to buy the 6th edition because what the heck am I doing reading the 4th edition when I'm working in a 6th edition world? So, error, YouTube is not receiving video to maintain smooth, blah, blah, blah. Okay, hold on. Or info. YouTube is not receiving enough video to maintain smooth streaming as much viewers will experience buffering. Okay. Do I need to just restart my computer? Is it working? Okay, I see green now. I'm seeing a green light. So I think it's working now. Check your resolution. It says that every time. I don't understand what I'm doing. The current resolution is this, which is not optimal. Okay, how do I optimize my resolution? Stream options, details. Video contains paid promotions. No. Betting, tags, live chat. No. Cancel. Okay, how do I create highlights? No. Edit? No. Video. Low stream latency. Okay, is it working? Alright, I want to start reading. So I got the 6th edition on Kindle, and I don't know if it's gonna. I think I bought it, so it's gonna get sent to me too. I think so. I have the hard copy and the Kindle, maybe. I don't know, but I'm gonna read here. I think it's good. So we're just reading timeouts, and I feel good with timeouts. At a minimum, this includes catheterization laboratory operator, his and her assistant, any anesthesia provider, and circulating nurse. Participates with active, out loud, verbal communication by all the members of the team is required. I concur is the proper acknowledgement. In particular, if there is concern about a possible error, no one should be afraid to speak up and protect the patient. Even when there's only one person doing the procedure, a brief pause to confirm the correct patient. Good connection. It's not working. It says good connection. Is this working now? This is really killing my vibe. This is killing it, dude. This is killing it. I can't do this. I just need to study on my own, I guess. This is too much work. This is distracting me from my studying. This is not good. Error? Is there a way to restart? Can anyone hear me? Is this working now? Okay, I guess it's working now. The reverse timeout, or I need 2 minutes. I don't know what that is. Reverse timeout. I'm going to say it's working. Okay, reverse timeout. I need, quote unquote, I need 2 minutes. A timeout before the procedure is a routine safety requirement. However, another kind of timeout is sometimes needed when the case goes too fast. This is especially true when over-eager fellows and catheterization laboratory attending physicians who sometimes want to work so fast that they outstrip the ability of the catheterization laboratory team to keep up with their demands or become confused by the conflicting or changing orders from the operators. Whenever this happens, anyone working in the laboratory can call a timeout, which is stated as out loud as, I need 2 minutes. The operators should stop and take a breath. This gives the person and the team who called time out a couple of minutes to uninterrupted time for him or her to get everything caught up and correct. For example, when the circulating nurse is asked, please give me the patient nitroglycerin, give me a JR4, 6 French, set the injector at 12 for 36, and show me the ECG. It is clear that this is too much to do quickly enough for the smooth operation of the lab, so the nurse should call for 2-minute timeout. The called 2-minute timeout is the request back to the operators to give the nurse technician or team 2 minutes to get all the steps, equipment, or setup going and correctly brought together. During complex procedures, the nurse can say, I need 2 minutes to do XYZ. Everyone will hear and should understand. The operator will relax and wait for the team to catch up. Of course, the called timeout would not be appropriate if there was a critical situation occurring in which the patient could not wait for an emergency drug or other life-sustaining intervention. For example, LV support device or an intra-aortic balloon pump insertion. I need 2 minutes before I can set up the intra-aortic balloon pump. Well, 2 minutes is going to leave him dead. So, okay, sterile preparations. Cardiac catheterization occurs in an operating room environment, and all preparations for the procedure must be performed using aseptic technique with personnel in scrubs, protective hats, mask and gown. Some labs do not require masks during the back table setup. Vascular access site preparation. The most common vascular access site is the right groin for the femoral approach and the right wrist for the radial artery approach. Hold on, I'm going to turn off my my loud fan so I can hear this. Back at it. Here we go. So I guess I got it working. Okay, so I'm going to go till 8 o'clock, and then I have to go to bed because I just got off work, and I have to go to work tomorrow. So let's do it. Here we go. Back to vascular access prep. So, of course, the left-sided are. So I'm reading directly from the book, and I'll comment as I read to process this. And this is how I process. So just so you understand, anyone listening understands my learning process. When I'm reading it, I'm saying out loud, I'm responding to my thought, and then I'm also, focusing. This all brings it together and really helps seal this information in my brain a lot of times, or at least lets it wash over my brain and it'll retain a lot of it. So here we go. So I'm going to read out loud, and if anyone has any questions, if you're watching this and you're live and you want to ask a question, or you have a thought, or you want to chat about something, feel free to throw it in the comments, and I'll see that, and I will talk with you because that's fun. Okay, the usual sterile preparation begins by clipping the area of hair and vigorously applying an antiseptic solution. Shaving should be avoided because of microlacerations or abrasions breaking the skin barrier to infection. During patient preparation, the staff should always be aware of the patient's need for privacy. Curtains in the viewing area should be drawn. Patients should be kept covered as much as possible, and this procedure room are typically cold. Every effort should be made to keep the patient warm and comfortable. Sterile for interpretation and patient draping. A staff member assigned to assist the physician in the procedure puts on hair and shoe covers and a surgical face mask and washes the hands and forearms as a surgical scrub. He or she then puts on a sterile surgical gown and gloves. An equipment stand is prepared in a sterile fashion to hold all of the catheters and other equipment to be used during the procedure. At this time, a circulating staff member hands open the sterile packaged catheters as necessary equipment not included in the sterile catheter laboratory pack to be taken by the scrub nurse or technician. A sterile drape is placed over the patient, starting with upper chest and expanding to the foot, covering the entire examination table. Special arm reconnected. No data. Gone. Why does it do that? Oh well. I am going to just keep, I'm just going to keep doing this. I'm just going to keep reading. So I don't have time to fiddle with this. I'm live. I'm studying. If it doesn't work, that's the way it goes. It's just the way it goes. Rules for observers in the laboratory. I'm not going to worry about that. That's not a big deal. Okay, as a basic rule, no unsterile objects may be passed over the sterile field. Okay, I know this stuff. Sterile gown and gloves rather than gloves alone should be worn when preparing a back table of patients, especially for the members who are very short or wide, or those who may typically... Is it working now? Okay. All right. So, when moving around crowded angiographic, I'm good with all that. I read all this stuff. This is all the same as the 4th edition. So right now I'm getting a little ripped off. That's okay. I'm sure I'll find good stuff. So conscious sedation for invasive cardiac procedures. I don't know if this is going to have changed from what I read in there. The purpose of conscious sedation to minimize patient anxiety, discomfort, and pain sedation. All right. So I'm good with. I feel pretty good with conscious sedation. So I'll do a conscious sedation rant. So conscious sedation. Yeah, our conscious sedation involves we do fentanyl Versed. So you can do like 0.5 milligram of Versed or 1 milligram of Versed and 50 milligrams of fentanyl or like 100 milligrams or 25 milligrams of fentanyl. And you can do those together, boop, boop, or you can do it one, boop, or you can do the other one, boop, or you can give them boop, boop. So that's, and then you do it Q15 basically, because these drugs are rapid acting, they metabolize quickly, and they wear off really fast. So fentanyl, it's got 15 to 30 minutes, and then it stops working. Versed, it stops working really fast. So that's why they're great medications, because you can give them, boop, boop, shuts off their, makes them sleepy for 15 minutes, and then they start to come back to it. So you can kind of juggle your sedation level. And so you have multiple depths of sedation. You have like minimal sedation, right? Or you have, then you have moderate sedation, then you have deep sedation, then you have anesthesia. And at anesthesia, you've lost your gag reflex, you've lost your respiratory drive, you may be hemodynamically unstable, you're requiring an advanced airway. And then deep sedation, you've lost your reflexes, like stimulus, so that you may not respond to pain, and you may have a depressed respiratory drive, requires like a jaw thrust, but it comes back. And then moderate sedation or conscious sedation, where we like to keep them, is kind of where we want them. Is if you tap on them and say, "Hey, Johnny, can you wake up for me?" They'll open their eyes or they may respond, "Do you feel okay?" And they say, "Yeah, I feel good." And then you have like mild sedation, I guess, or like I don't know what the word is, but it's like really, it's not anything. So that's not where we're at. So we want to keep them between moderate and deep. So we don't want to get them into deep for too long. We want them in moderate sedation. Moderate sedation is good. And one of the rules of thumb for anesthesia or for moderate sedation is always manage sedation one step above, before what you can't manage. So you're not supposed to manage deep sedation. You have to be comfortable managing. If you can't make an advanced airway, you don't really want to be managing deep sedation. You don't do deep sedation if you can't manage anesthesia, if that makes sense. And so you do moderate sedation because you can handle deep sedation, but you don't want to keep the patient in deep sedation, because then you're doing jaw thrusts and you're putting masks on them, putting on BiPAP, all this weird stuff to keep their oxygen saturations appropriate, and now you're managing their airway too much and you're not able to help out other ways because you have to be there, and you can knock out their hemodynamics as well. So those are just a few things that I know about moderate sedation. Okay, so let's go back and see what he says. So the purpose for conscious sedation or moderate sedation is to minimize patient anxiety, discomfort, and pain associated with the procedure. The following criteria define conscious sedation, okay, or moderate sedation. Conscious sedation, moderate sedation, same thing. Patient has at no time loses protective reflexes, so they don't lose an airway, right? You don't hear them like I suck. I have such bad internet. And then all of a sudden it starts working again. What I'm just a poor man who doesn't care if my streaming service, whatever I use, the software I use sucks, and I don't know what I'm using. OBS software, I guess. I don't know. Okay, so if the patient no longer do so, I'm back on. I'm back in. I'm in it. It's working now. For some reason, now it's working. So I don't know why it started working again, but I'm seeing that I got a green light. I see the green color, so I'm assuming I'm working. So I'm going to keep reading. Patient responds appropriately to the law. The patient can no longer do the things listed. The sedative technique has evolved to deep sedation or general anesthesia. At this point, the monitoring and care of the patient must be elevated to avoid an adverse outcome. A conscious sedation protocol has 4 major components. Pre-procedural baseline assessment, okay. Drug dosage and administration, okay. Patient monitoring, all right. And post-procedural. Is it working? Am I connected? Is it working now? I think I need to update. Maybe I think this thing said it needed an update. And maybe my streaming service software just needs an update, and that's why this is going on. Who knows? Okay, here we go. Procedural assessment. Here we go. For administration, sedation patient should have a complete assessment of his or her current physical condition. Okay, look, I got 3 minutes. The clinician should pay particular attention to pre-existing conditions that would put the patient at risk for an adverse outcome if sedatives are administered. Okay, like obstructive sleep apnea, a bad melon potty, any kind of throat or mouth surgery or throat or mouth restrictions that would prevent or increase risk of a bad airway. Hey, how's it going? Okay. Pre-procedural evaluation should be reviewed. Major organ systems. Okay, so yeah, and you want like kidneys, check kidneys. So creat, BUN. Do they have a fistula? Are they on dialysis? Heart failure. So what's their ejection fraction? Is it right-sided or left-sided heart failure? Is it preserved ejection fraction? What's their ejection fraction? Do they have any kind of stenosis or coronary artery disease? Do they have peripheral artery disease? Because that can tell you that they probably have something going on in their heart too. Are they diabetic? That's a big. Are they insulin dependent diabetic? That should be a big red flag. So all these things, you're going to be checking because they can all have a direct impact on the safety of the sedation. So organ systems, okay, yeah. So respiratory too. So do they have chronic obstructive pulmonary disease? Do they have chronic bronchitis? Are they on permanent oxygen? These are some things that you really want to be aware of. The time and type of last oral intake. Yeah, they've been MPO. A history of drug and alcohol use. Sure. A history of smoking. A history of previous experience with sedative agents. Oh yeah. Pre-procedural fasting is the rule. Sedative agents may impair airway reflexes, placing the patient at increased risk for aspiration of gastric contents. For elective procedures, these risks can be minimized by allowing sufficient time for gastric emptying before the procedure. Patients should not be MPO for solid or non-clear liquids after midnight or at least 8 hours before the start of the procedure. So we don't really do that. Clear liquids may be appropriate for 1 to 3 hours before the procedure. Yeah, we do that, depending on the type of dose sedative agent we use. So like fentanyl Versed is not going to cause like, I mean, at least from my understanding, fentanyl Versed doesn't cause emesis. It's not going to make you puke or aspirate usually, especially if you're using small doses, half a milligram or 1 milligram Versed and 25 or 50 mics of fentanyl every 15 to 30 minutes as needed. That's not going to make them puke their brains out, hopefully. So that's one thing. But you don't want a full stomach. I mean, that's not ideal, of course. Okay, we'll keep going. Clear liquids may be appropriate, blah, blah, blah. We talked about that. Physical examination, airway assessment. Okay, so we do a mallet and potty, and we check an ASA. ASA stands for American Society of Anesthesiology. And so there's level 1, 2, 3, 4, 5, 6, I think. And then a mallet and potty is a 1 through 4. So we kind of chatted about this before. An airway assessment should be part of the procedural routine. And so what do you do for an airway assessment? This is the last time I'm going to do it again.